Okay, I think we'll get started. Thank you all for coming. My name is Odishaw. I'm one of the co-owners of the Bhakti Brain Health Clinic and one of the co-presenters tonight. Our co-presenter, Fran Bieganek, a licensed psychologist and again, co-founder of the Bhakti Brain Health Clinic. And then we have Adam, stand up. So Adam is our main tech in the clinic. And so he does the majority of our sessions. And then tonight, he's actually going to take a volunteer and wire them up and do a little bit of heart rate variability and neurofeedback training with whoever is brave enough to get their hair messy. So thank you, Adam. And then Heidi is our clinic manager. And so she does all of our community outreach. And so many of you probably know Heidi or have seen her name. Done a fantastic job helping build our community. I think we're going to just jump right into it. We're all set. Yep. Okay. I guess we should ask, is there anybody who would like to volunteer to be our demo for? Okay. Perfect. Oh. Excellent. Half the work is already done. Okay.
We're going to kind of trade off on the information that we're going to share with you. So I'm going to share a little bit with you about our clinic and begin to talk about our assessment process. And then I'll kind of tandem it back to Guy and he can tell you a little bit more. We are at Bhakti Brain Health Clinic. We consider ourselves a center for excellence in brain health. And part of the reason we think about it that way is like kind of what distinguishes us from other places that might be engaged in some of the similar training and treatment processes that we use is the tools we use, the training we do, and the time we commit. So we have made a conscious effort to make sure that we bring into the clinic state-of-the-art equipment so that we can do very specific and thorough assessment and then provide kind of cutting-edge training for our clients, whether that be neurofeedback, neurostimulation, photobiomodulation, all of those sorts of things. And so it becomes helpful for us. So in terms of the tools we use in regards to assessment, and then how we address the dysregulation that we find in assessment. So our equipment allows us to do quantitative EEG, which is brain mapping, and that's kind of the standard brain mapping that people would think about. We also can do evoked response potential. We we bring in heart rate variability assessment and training. We include in our assessment cognitive functioning assessments. We use the CNS vital signs for that. We include mental health diagnostic assessments to kind of look at what might be going on behaviorally and emotionally that might be impacting a client that comes to see us. And then we also pull in genetic testing. And so that's part of what we think distinguishes us from other clinics that may be doing some of the neurofeedback. The training we do is we, again, have included a lot of different modalities. We train both in the clinic. We also do training. We have devices that you can use at home that can either be used on their own or can be supplemental to the training that we're doing in clinic. And then we also work like with schools and other organizations, bringing devices into them to help them work with students to regulate emotion, those sorts of things, so that students can remain in school, be more successful. And then the time that we commit also sets us apart. We spend a good amount of time making sure that we are up to date on what's going on in the field. So that sense of kind of ongoing continuing education that just is a part of sort of how we live life. It doesn't even feel like a thing we do. It just sort of is how we go about life. And we work hard to identify cutting edge interventions that are happening, staying kind of on the cusp of what's coming so that we can learn about it and then determine whether or not those things will be helpful for our clients in our clinic. And then the our direct service to clients, we see we have a real passion for committing time to our clients. And so we will go above and beyond to make sure that we're communicating with clients, providing them with input about their training process, problem solving when they run into problems. And we see that piece as a significant part of the time that we commit. So it's these three things: the tools we do, the training we do, and then the time we commit, that really for us distinguishes us as a center for excellence in brain health. This is just a list. I'm not going to go through it. It's a list of some of the people that have influenced us along the way, both provided training for us or are mentors for us. And as you can see, there's a variety of individuals on here who continue to inform the practices we use. So one of the things that makes Bhakti Brain Health Clinic unique is that as a clinic, we do both assessment and training. So oftentimes a clinic is either specializing in assessment and that's all they do. And so you go to see them and then they refer you out for treatment or training. Or somebody's just doing the training, and so to get the assessment, you have to go somewhere else. We provide both, and we're going to spend some time talking with you about what the assessment process looks like, what the components are in that, and then we'll also share with you some information about the training processes that we use. So our assessment process is kind of a holistic approach to assessment. We are unique in this way. We kind of use this metaphor of a three-legged stool to highlight what we do with assessment. So we have a cognitive behavioral component to our assessment, which includes the CNS vital signs assessment. And we do a mental health diagnostic assessment as well. Then we have a brain function component, and that's the quantitative EEG and the evoked response potential. And then the biological component of the assessment is the genetic testing that we have clients do. We have a firm belief that thorough assessment can lead to clarity in diagnosis. Even though we in the clinic do not diagnose, our assessment is a component of understanding what's going on with the individual. And having clarity about that can then lead to more efficacious treatment and ultimately better results for the client. So our neurocognitive and diagnostic assessment. So this is the cognitive behavioral component of our assessment. So we do an assessment. The CNS vital sign assessment that we use is an online computer-based assessment that the individual does that allows us to assess the integrity of their cognitive functioning. And it allows us to kind of identify any mental health markers that might be there that we might want to do some further talking with the client about. The assessment includes all of those things that you see there on the screen in the little bubbles. So it assesses things like motor speed, attention, working memory, reaction time. There's a whole bunch of categories of assessment that we do that are included in the CNS vital sign. So we take that information and we use that as we look at the data we get from their QEEG, from their evoked response potential information that Guy's going to talk with you about, but that is compiled together so that we start to get a better picture, which can help to provide us the neurocognitive testing can help to provide kind of a baseline for us as we begin training with the client so that we can kind of follow over time how our training might be impacting the cognitive functioning in these areas. The mental status exam is part of the diagnostic assessment that we do. A diagnostic assessment is meant to identify any kind of like mental health disorder, right? So those things that are in the diagnostic and statistical manual of mental disorders. So it's used for that, but it's also used to just kind of look at behaviorally and emotionally are there things going on that may be impacting overall functioning with the individual? And we can use that information both in what we're doing in training. Sometimes it's a matter of, okay, I think in addition to what we're doing, let's have you also work with a therapist on some of this skill-based stuff. So we might refer them out for additional treatment while they're training.
I'm just going to back up one. From our perspective, we think of these as behavior. So this is what we can see or kind of measure at the level of behavior. When we go to EEG, we go actually a long ways away from behavior, where we start to look at the neural underpinnings of what eventually becomes behavior. And I like to say it's like the distance from here to the moon, the distance from what we look at from a neurophysiological standpoint versus what we look at a behavioral standpoint. I'll give you a little bit of a sense of what do we do. So we have the QEEG, so Quantitative Electroencephalograph. So this is a resting state. So we look at what the brain is up to when it's idling. So what are the kind of habitual patterns of neural activity in the brain when it's idling? And then we do an event-related potential. So this is, what does the brain do when it's given a task? So it's a specific task that is well understood how a neurotypical brain will execute this task. And we basically take a snapshot of that brain doing the activity. And then we look at how did that information specifically move through that brain to take from input to output. And then we analyze that in millisecond detail. It gives a lot of information about how this brain does computation. And so you see a few examples up here on the screen of some of the information that we get. And I will say, again, one of the things that differentiates our clinic from other clinics is the depth of analysis that we do. When we do a QEEG, we'll do an eyes open and eyes closed. We do an ERP, so about 40 minutes of data that we acquire. We run that through 3 different artificial intelligences to get different interpretations of that data. And then we do a by hand analysis of that EEG, the entire record of the EEG, so that you don't only have 3 AIs, but you've got an experienced clinician that's looking at the raw data as well. And all of this comes together in making our report. I want to talk a little bit about like the EEG and why, and just kind of differentiate it a little bit from some of the behavioral piece, where most of us are used to thinking and talking about and hearing about people's behavior, but we're not used to looking at the neural underpinnings. So an example of this might be, you think of an athlete. So I was a competitive athlete, and I would spend time on the mat with a coach teaching me techniques, how to do the activity, and maybe the rules of the sport. So I understand how to play the rules, how to do the techniques. But then I would spend time with my trainer, and we'd do something like plyometrics. Anybody done plyometrics before? You get one nod, right? It is, in a sense, I want to say it's the most useless activity, but it's not. It's really good for training one thing, but it has nothing to do with the sport, right? It is completely sport agnostic. So you do plyometrics, and let's say you're standing by a box, and they want you to jump up on the box. That's it. That's what you're doing in the plyometric session. And then they give you a higher box and a higher box and a higher box. And what they're training is basically recruitment. When you fire the nerve, right, to make that muscle fire, how much of the muscle volume can you recruit, right? That's what you're training. Neuromuscular connection has nothing to do with the sport. You're going to go use that in, right? You could use that skill that you've developed, you know, that neuromuscular recruitment in any sport. That's what we do, right? We teach the brain on this level of function, not on the level of behavior, long distance away from behavior. So by improving function, it can be used in any behavior, math, reading, making better decisions about relationships, what car to buy, you name it. That new neural circuit can serve you wherever you're going to use it. Right? So here's an example. One of the things we look at quite a bit in our work is how networks, how groups of neurons are communicating with each other. So if you look at these two pictures, they don't look all that different, but they are completely different, right? So the top one is dystonia. So that's a muscle contraction pulling this part of her face down. That's an active contraction. The other picture is Bell's palsy. That's an absence of muscle tone. So that's collapse, right? So they kind of look similar, but their mechanism, the reason they're there and how you resolve them, completely different, right? So we can see behavior when we're looking at a child, if we're doing evaluation, we can see a behavior, but we don't know necessarily why that behavior is there, right? And that's where EEG comes in. It can tell us if, and we look at these two images here, the excess kind of yellow and red in the top one, that's hyper coherence. That's neurons that are firing and staying wired together too long. So that's like the tonic contraction of the dystonia. The other one, if you look at where the blue is, right, that is where neurons that should be wiring together aren't. So that's gaps in the communication network, right, where there's no firing. So that's hypocoherence. No information, no computation is happening at that moment. The outcome of those two things and the downstream ramifications and how you treat it, completely different, right? So that's the value that doing the EEG brings, is we can understand what's happening at that neurophysiological level. Again, way before it's anything like behavior. A little later, I'm going to say a little bit more about EEG, but so this is the genetic piece. Why genetics? So, one of the things that we learned early on from our mentors is if somebody is having, a behavior level issue, and we come along and we're looking at it from a neurofunctional standpoint, and we're trying to correct it, but really the issue is metabolic, right? The question becomes like, what are we doing trying to change the brain to change to correct a problem that's happening in the body? Right? It's inappropriate care. So for us, we want to know where are those, from a neurofeedback standpoint, what we call confounds. Where are the gaps in this person's metabolism that are showing up as functional deficits in the brain, but the problem isn't in the brain. If you fixed it in the body, the brain would be fine, right? So what we found is this particular company that does genetic SNPs, and why we like this particular company is their solution is a customized supplement that's based on your genetic SNPs that is not about filling holes. So let's say you've got a genetic mutation that you don't produce vitamin D very well. You don't convert vitamin D very well. Most companies are just going to supplement you with vitamin D. This company, their approach is fix the epigenetics so that you start to metabolize vitamin D naturally. This is a completely different approach, and that's why this is the first company in 25 years I've wanted to work with on this level of genetic SNP and functional medicine. Is we're not filling holes, we're solving the problem at the level of the genome. And so it's a novel approach. And I will say the other piece that's attractive is their price point. They come in for the technology that they're bringing to play. They're very affordable. Say kind of our mantra in the clinic is we don't treat conditions, we regulate dysregulation. Right? And it goes a little bit back to what I was saying at the beginning of the distance between behavior and the neuro correlates that might be building to that behavior. So whether a person has anxiety, depression, OCD, traumatic brain injury, dementia, from our standpoint, when we're working at the level of the neurons, it doesn't matter what the condition is. Our approach is, what's the dysregulation? How do we regulate it? There's a trust, and it isn't just a trust, it's a lot of evidence to support it, but we'll say it's a trust that if we regulate the dysregulation, those behaviors we were calling symptoms just start to fall away, right? Without ever us trying to treat, say, anxiety. All we did was lower the amount of beta activity in a certain part of the brain. And lo and behold, the person says, I don't have my anxiety anymore. Right? So that's the idea behind what we do is this idea of we don't treat conditions, we regulate dysregulation. Up here, we've got some of our, the ways in which we do this. And so we're going to go into some of the devices. So these are the modalities. We're going to go into each device in a little bit more detail. So I'm not going to speak to them now. I'll just say generally, whether we're working with a person in the clinic, doing neurofeedback or neurostimulation in the clinic, where we have the most sophisticated equipment, then we have versions of that that are at home. So I like to say that it's the difference between a scalpel and a snow shovel. In the clinic, we have the scalpel, very precise, very sophisticated equipment. But then we have our at-home devices that are quite potent, but they're not very specific. We have, great success doing neuromodulation at home. And our favorite, of course, is when we can combine and have somebody doing in-clinic visits, so maybe coming in twice a week, and we're having them treat at home 7 days a week with a device. So that brain is getting a lot of input to kind of stop doing what we don't want it to do and start doing what we want it to do. And then we get to polish that in the clinic where we have the more sophisticated equipment. So the idea of neurofeedback training, operant conditioning is a very basic paradigm. Pavlov and the dog is the cultural reference most all of us know. And so here what's happening is the computer is reading the neural activity, the electrical activity at the scalp. That's going into a computer. Often we're doing it compared to a normative database. Depending on how close is your brain activity to that kind of age and gender matched neurotypical database, you're getting feedback on how well or not you are doing moving information around your brain relative to the database. So you're getting feedback we're going to see in a little bit when you come up and we get to see your brain up here. We'll get to see you flying a plane with your brain. It's one of the common games that we use. In many ways, the interface doesn't matter. It could be old school, just like a light bulb that came off and came on and went off, is just a signal to the brain to say yes. In the absence of a signal, no. And the brain can take that and rewire itself just with that little bit of feedback. And that's the paradigm, is the brain is getting moment to moment, real-time information about its activity, and it's being told yes or no. And yes gets wired in and no gets pruned. Approach to neurofeedback. One of the metaphors, again, I like to use is when a person doesn't have the neural circuitry. So here, one guy has got his hands tied, right? So trying to juggle with his hands tied. And, it really doesn't matter how much you try and teach him the tenets of juggling. It's not going to go well. His hands are tied. And so we say the same thing. You can do cognitive behavioral therapy with somebody, but if they don't have the neural wiring to grasp what you're asking of them, they're not going to be successful. Or the person with ADHD, if you talk to them about like, I need you to be here on time. I need, class starts at, or you get up at, and you're talking to them about time and you just blank stare, or, they're agreeable maybe. But the circuitry isn't there to produce the behavior. Right? And for our side, this is our constant refrain is, before we start doing the skills-based, let's start putting the neural circuitry in place so the person has the infrastructure to be successful at the activity, instead of asking them to use different wiring to try and produce the outcome you want, but it'll only ever be an approximation. It'll never be the skill that you're trying to get from them because the wiring of the skill isn't there. So this is, again, our perspective from neurophysiology. How can we build in the neural infrastructure that behavior is produced from?
So another thing we do in clinic training is neurostimulation. So neurostimulation neurofeedback is a learning paradigm where you're teaching the brain how to develop that neural circuitry for kind of the long run. Neurostimulation is more of a treatment paradigm. And so it's, in the moment, teaching the brain to produce particular brainwave frequency in a certain area based on what the protocol is set at. So our neurostimulation equipment does both direct electrical stimulation, so we can do alternating current or direct current stimulation. We also have pulse magnetics. So what you see up there on her head, those are magnetic. That's the magnetic stimulation. Underneath that cap, we have sensors on her head in certain areas, and those sensors are what are providing the electrical stimulation. What this intervention can do is promote like regulated brainwave functioning and so like I said, it's just sort of training the brain to produce that particular frequency. Oftentimes we will in training start somebody off with neurostimulation as a way to sort of just kind of jumpstart the process, and then maybe 5 to 10 sessions of neurostimulation, and then we'll move them over to doing neurofeedback as a way of kind of moving into that learning paradigm that's going to produce that kind of long-lasting brainwave change and development. Audiovisual entrainment. So this is one of our neuromodulation interventions. This is a device that can be used at home. Sometimes we use in the clinic. I, as a therapist, use this with people who I'm working with oftentimes when they're really dysregulated, and I know that no good therapy work is going to happen because they're ramped up too much. We use an AVE while we're doing therapy as a way to sort of get the nervous system settled down enough so that we can tap into their frontal lobe and do some of the work that we need to do with skill-based kinds of interventions. So the audiovisual entrainment, again, is a treatment device. So this is providing auditory and visual stimulation to the brain, again, at particular brainwave frequencies based on whatever protocol that the person has the equipment set at. It helps the brain to get in sync with those frequencies by speeding up or slowing down, depending on what we're doing. So for example, if we wanted somebody to be able to produce more of a calm kind of brainwave process so that they can settle down, we might have them doing an alpha protocol, just kind of in that meditation brainwave frequency as a way of sort of slowing the brain down. So what happens is the stimulus starts to kick in. They see pulsating light in the goggles, and then there's pulsating sound, both at the same frequency in the headset. And as that starts to happen, the brain begins to kind of move over, it start to mimic that and then to begin to do that. What it can be really good at is strengthening those neural pathways. And so we have a lot of clients who will use this in addition to the in-clinic training that they're doing with us. So it's supplemental to the training. But then we also have a set of clients, some local, some in different areas of the country, who are using this equipment to manage things like anxiety, sleep issues, trauma, like PTSD, that sort of thing. We have a lot of, we have schools that are using the audiovisual entrainment as a way to keep their kids in school. So kids who might get really dysregulated and have to be pulled out of school, they have these devices in their resource room, and they can take the kid, put the device on them, run a protocol, and the kid gets to go back to school. So less interruption of their school activity. And then photobiomodulation. So this is another device or a treatment modality that we often have clients doing at home. So we're talking about red infrared light therapy. We have several devices. This is one of them. This is a helmet that we use. And so it's literally providing infrared light to the brain. We also have some other devices. I think we have them back on the table. You can take a look at them later on, test them out, see what they're all about. So red light it's a primary site of light absorption in mammals. The mitochondria is, right? And so red light is focused on enhancing the mitochondria signaling. And it also does a really nice job of reducing inflammation. And so oftentimes we'll use this with people who have TBI or have had a concussion, people who have early cognitive decline, dementia, that area. And then also sometimes with people who are on the autism spectrum, especially if they are people who maybe aren't able to do the services that like the in-clinic services that we do. This is a really nice intervention. There's some really good research out on autism and infrared light therapy. So rehabilitating mitochondria, improving blood flow to tissue. So really creating more of a healthy brain that then can respond to the demands that it faces. You're here tonight to talk because we wanted to talk about anxiety and ADHD, right? So we've given you some overview of what we do in the clinic. And we want to talk with you a little bit about anxiety and ADHD. We're not going to spend a ton of time talking about statistics and things like that. Most of you that are here likely understand anxiety and ADHD in some fashion, or you probably wouldn't be here, right? But we do have some statistics. It's interesting. The kind of recent or current statistic on the comorbidity between anxiety and ADHD is about 50%. So that's half the people who have ADHD also have anxiety. A pretty significant number. And so they just kind of go in hand. We see that in the clinic all the time. Clients who present with symptoms, they either come in for one or the other. And we find that there are these other pieces of it that are a part of the picture. People with anxiety, you can see here that the numbers are just like, every time I look at them, I think, holy gosh, that's a lot. You know, a third of the population that has, that meets the criteria for an anxiety disorder. People with anxiety disorders are 3 to 5 times more likely to visit their doctor for particular issues. They're 6 times more likely to be hospitalized for a psychiatric disorder. It's a pretty big statistic. So anxiety is can wreak havoc on an individual's life. What we know about, what we think about as causes for anxiety in the clinic, we look at the idea of the brain dysregulation, that the stuff that Guy was talking about, genetics, personal and life events can also have an impact on somebody beginning to experience anxiety. Dysregulation somewhere in the person's system. That's really what anxiety is. Could be dysregulation in their brain functioning, right? And so we assess that through the use of a QEEG, the quantitative EEG, and the evoked response potential. We address it with neurofeedback, neurostimulation, neuromodulation, one of those treatment options. Anxiety might also be a dysregulated autonomic nervous system. Right? And so that's going to require something different. And so the way we assess that is through biometrics. So we do most often when we do a quantitative EEG, so when somebody comes in to do a brain mapping, we also do heart rate variability assessment. We're assessing their autonomics to see how they're functioning. It can give us great information about whether or not we need to intervene at that level as well as the brain function level. So the way we would address that typically would be through heart rate variability training. We might also do some biofeedback for muscle tension. We have a bunch of clients that have, you see their anxiety show up in the jaw, right? And so they have a lot of jaw tension, and we can do simple biofeedback right before we do neurofeedback with them to help train their system to begin to relax and release some of that tension. It could also be a genetic expression. The way we assess that is we have clients do genetic testing, which will give them information about whether or not they may have a genetic component to the anxiety that they're experiencing. If it's genetic, the way we're going to address it is through those nutritional supplements that Guy was talking about. It also could be stress in the environment causing the anxiety. So the way we might address that in the clinic in terms of, or assess it in the clinic, is with that mental health status exam, right? We can do a diagnostic exam with somebody to see if there are certain life circumstances, behavioral patterns that may be contributing to the anxiety. And then the way to address that would be through skills development, referring for therapy, those sorts of things. This slide is showing you kind of typical EEG markers for anxiety. So these are the things that we might see in a brain mapping and in some of the results that we get that might indicate to us, yep, this is a brain that probably, like, this person is likely experiencing some anxiety. And this may be the reason why. So I'm not going to spend a ton of time talking about all of this because I want to have an opportunity to make sure we get some case study in. But just to note here that things like, too much frontal beta can be correlated with those kinds of anxiety symptoms. Occipital beta associated with kind of a general sense of unease, right? So we're looking here, that frontal anxiety or frontal beta in excess. Here we've got occipital beta in excess. And then Guy had talked with you about that idea of hypercoherence, and that when we see hypercoherence like this, it's oftentimes correlated with anxiety. It's a cortex that is just far too synchronized, right? And so it gets kind of locked in a rhythm that's kind of excessively rigid. So these are EEG markers that might help us understand what's going on when somebody presents to us with anxiety. And that what we're going to do is work on training those, like training that dysregulation. It informs us where we want to focus our training. There are some, we put some prevalence rates of ADHD up here. I think the big takeaway here is that people who have ADHD, nearly a third of kids that have meet the criteria for this diagnosis right now, that there's strong correlation with them in later high school years dropping out of college, and also correlation, or out of high school, and then also correlations with them never kind of doing any further education. Higher risk of antisocial behavior, anxiety, depression, those sorts of things. And so clearly, again, a significant reason for why we want to help folks who are struggling with this. There are, when you talk about ADHD, in the field of mental health, when we talk about ADHD, we talk about the three types. We talk about ADHD with hyperactivity, impulsivity, with attention problems, and then there's a combined type, right? When we look at brainwave functioning, there are actually 8 EEG profiles, and they're listed up here. And so not every ADHD looks the same. So if we were just to have somebody come in and say, I have been diagnosed with ADHD, and we say, oh, okay, we know how to treat that, and we just train it on a basic protocol for ADHD, we might completely miss the boat, right? Because we're not training the actual dysregulation. This is why we find it important to do the thorough assessment that we do, because it gives us a clear picture of what is going on so that we know specifically how to address it. The first case study is going to be about anxiety. And then Guy is going to give you a case study having to do with ADHD. So the case study on anxiety. So this is Corey. Corey was a client of ours who came in because he was experiencing significant anxiety and it had gotten so severe that he was not able to, it was interfering with his work. And the anxiety that he had was a result of a reaction to an antidepressant medication, actually, which oftentimes happens. And it's, there's an irony in there, I think. But he came in, and most of his anxiety, he's going to share his story with you here in just a minute. But most of his anxiety had a physiological component to it. And so that was part of what helped us to decide which kind of training we were going to do with him. And so he's going to tell you, we did neurostimulation with him. We did about 20 sessions with him, and I'm going to let Corey tell you about how that went.
And Adam at the Bhakti Wellness Center. I'd been struggling with pretty significant just physical symptoms of anxiety. I had been doing pretty helpful talk therapy, and so a lot of my anxious thoughts had calmed down quite a bit. But I still had these physical symptoms of anxiety. When I would get nervous about something, I'd have this clenching feeling in my belly or in my throat, or my heart would be racing, things like that. And it was really getting in the way of my work and just my enjoyment of life. And so Fran recommended neurostimulation. And I was open to it, but I really didn't know if it would help or not. And after we found the right frequency for the neurostimulation, I was amazed. The physical symptoms of my anxiety almost immediately went from like a 6 or a 7 to like a 1 or a 2. And I continued to do neurostimulation for about 20 sessions or so, just to make sure that the treatment really kind of lasted and the effects would stay, the benefits would stay. And all the while that I was doing that, I felt really cared for, and I felt like what I had been struggling with was really important to Fran and to Adam. And I still, to this now, I feel that those symptoms have very, very much decreased. So I really recommend the Bhakti Wellness Center, and I had a very
good experience there. So Corey is an example of somebody. Guy was talking a little earlier about that idea of, you can't teach a skill if the circuitry isn't there for the skill. Corey's a really good example of that, because he had been doing a lot of talk therapy. He'd had this going on for about 3 months. He was so miserable when he came in to see us. And he had been doing talk therapy, doing all of what we're supposed to do. And Corey is a therapist, by the way, so he knows the skills for managing anxiety, right? It didn't matter what he tried to do, it wasn't working for him. And the reason it wasn't was because he didn't have access to do it, right? His brain had become dysregulated in a way that wasn't allowing him to engage in the skills in any effective way. And so as he started to experience relief, which was, I think, session 3, we switched protocols after the second session because there wasn't seeming to be much happening with the protocol we'd started with. He immediately, in that third session, started to feel relief, and then just continued to feel it. I check in with Corey regularly just because I'm curious and because I care that he's continuing to do well. And he's like, he doesn't ever need us again, I don't think, which is good for him, right? I think he's just a nice example of why it's important to make sure that you are addressing the brain function so that people can be successful at developing the skill that they might need then to deal with the anxiety or ADHD or kind of anything else. Okay. Yeah. Yes, that's exactly it. We want to look at things comprehensively, right? And so it's possible that somebody could have a genetic component and EEG stuff showing up, right? So we just want to know what's there. We kind of don't want things hiding behind the curtain.
So I just wanted to bounce back one slide here. So I'm going to reinforce something that Fran said, but I just feel like it deserves emphasis, which is the primary way we think about anxiety is the experience of dysregulation somewhere in the system, right? So often we kind of think of anxiety as a thing, right? Like you could go out in the world and find anxiety and it would be one thing. And from our perspective of looking at the physiology, neurophysiology, or just plain physiology, is there are no two anxieties that are the same. right? How a person is generating, where that dysregulation is coming from, thank you, is very unique to that individual. And so their path out is going to be unique to that individual. So again, you can have anxiety because you have GI issues, right? And you can talk about that all you want, or you could even try and do neuromodulation all you want. But if you don't resolve the dysregulation in the gut, you're not going to change the feeling of anxiety, because your anxiety is a signal that something is off, right? So that's, again, why do we take a comprehensive view? Is there's so many places that that dysregulation could be hanging out. We want to spend our time helping that person fix or regulate that dysregulation, and that is going to be their path out of anxiety. And then with ADHD, the piece that I like to emphasize is a couple of things. One, as Fran mentioned, we have the different phenotypes when we look at it from a neurophysiological standpoint. One of the things that happens when ADHD is being assessed is if their diagnostic categories are too small, so they're inaccurate, people are kind of getting scooped into these very broad categories. They're being given treatments like maybe a stimulant medication when their particular form of ADHD is not going to respond to a stimulant. So they get the medication, the medication didn't help, medication doesn't work. Well, no, medication works for the system that needs that kind of regulation. That's all medication is a form of regulation. It's just chemical regulation as opposed to bioelectric regulation. So if you get the right match, you'll have success. And the case study I'm going to show you is an example of a group of people actually that were diagnosed with ADHD, and what they actually have is what an epileptiform disorder. So that's one of the most common things that happens in our clinic when people come in. About 50% of the people we see that come in with an ADHD diagnosis do not have ADHD, right? So half of the population coming in misdiagnosed. The biggest subset of that misdiagnosed are people who have some type of mild seizure condition. So if you think about it, you take somebody who has seizures and you give them a stimulant, you just made them worse, right? And if that's 50%, that's a lot. So it's one of the things why we're passionate about this piece of assessment is one, an ineffective assessment just leads to ineffective treatment. That's not helpful, but it's also the possibility that that treatment could make a person's symptoms worse. And that's, of course, the one we want to avoid. When we started doing this, our mentor said, if all we did as clinicians was just ADHD assessment, we would make the world a better place. We see now why he says that, because of the rate of misdiagnosis and therefore poor treatment. Summary maps, so the EEG summary maps, and then some specific maps down at the bottom. I'm not going to talk too much about the maps and the dynamics, but what was remarkable to me is, so I had the opportunity to do a QEEG on the mom and 3 daughters. The dad was resistant to coming in, perfectly fit his profile. So what this family was kind of known for, and what they had diagnostic labels for, were anxiety disorder and ADHD. And you would not disagree if you met any one of these people, right? It would not take you very long and be like, wow, you're super anxious, and you don't pay very much attention, and you would instantly label them with ADHD. So they had gone down the path of various medications for their anxiety and various medications for their ADHD and various cognitive behavioral trainings and the kids in school, various accommodations, all being ultimately not successful, right? They weren't solving the problems. They were ranging between making them slightly not as bad or slightly worse. That was it. So eventually they heard about neurofeedback. They came in, did the QEEG on the first, and saw the findings, which then led to the next one, the next one, and the next one coming in. And what we found was what's called epileptiform activity. So epileptiform activity is a fancy word those of us who are not neurologists use instead of saying epilepsy. because we, Fran and I, and people who do neurophysiology would never say the word epilepsy, get you in trouble. Only a neurologist can say that. So we say epileptiform activity. So when I saw their EEGs, I said to them, it looks like this is epileptiform activity. My suggestion is we send your reports out to a neurologist, you have this reviewed by a neurologist and have a consult for epilepsy. And the answer was just no. Do not want to open that door. Don't want to know, don't want the diagnosis, nothing, hard stop. To this day, and we're probably 6 years post these mappings, they're still trying to handle their issues through psychotropic medications and ADHD modifications, and they're not working. Okay? But that's because they don't want the alternative. I will say a little bit about what's happening. So what they have and again, it's rare that you see 3 QEEGs, and if I could fit the 4th one on here and still see the maps, I would have put it on here. It's rare that you would see 4 QEEGs this similar. Like brains are just not that similar. They're too complex to be similar. This is a very strong family trait that we're seeing here. So what we're seeing is excess theta activity. And then we talked about these connectivity maps. We're seeing a mix of over and under connectivity. And the predominant finding being excess slow wave activity. And the best way I can describe what was happening for these people is imagine like your brain is a little bit like a whiteboard, a chalkboard, right? And you're taking in information, and that's like being written on the whiteboard of your brain, right? That's working memory. So imagine you're a person, you're sitting in a classroom, and the teacher is writing notes on the board, and you're taking down the notes, and somebody comes along and wipes the board clean. And then the teacher starts writing again, and then somebody wipes the board clean, and you're trying to learn. And there's like huge gaps in your information because somebody keeps wiping all the information off the board. That's what's happening in these brains. When these big theta bursts happen, these epileptiform, it just blanks the slate. What they think and what they've been told by clinicians are gaps in attention, right? When they're inattentive, they're not inattentive. They're in a seizure, right? Like they're gone. And then the world keeps going, right? And then they come back to the world, but the world has moved. They weren't there for it. So there's gaps in their information. And that they're proceeding as if that's ADHD. And of course, that leads to anxiety. You can imagine, like just try driving when you can't really see and the world is coming by you at 50 miles an hour and you can't really see, you get anxious. If that was your lived experience every day, you'd be anxious. So for me, like this value of distinguishing between a true ADHD and anything else, very important for whatever comes next. Correct. So we could line up a particular form or so these are the kind of the phenotypes, the different way that it shows up. And you could correlate these forms of the biomarkers for ADHD that we use in neurophysiology with the diagnostic categories. Yeah, so they line up. The problem is there's too few diagnostic categories. There needs to be a diagnostic category for every type of EEG pattern. And so yes, they correlate, but they correlate poorly. A bit about our process, just kind of in a nutshell. Yeah, go ahead. Yep. Yes, well said. Yep. So we have yet to, so the question is, how does it happen? For our folks that are online, the question is, how does this dysregulation happen? And so we have yet to do a QEEG on a brain absent dysregulation, right? And we do peak performance. So we have people come in who, they've performed above average or perfectly on every test they've ever been given. They're top of their career. They're successful in every category you could measure. And they're coming in saying, can you make me better? Maybe, but yes, actually you can, because everybody has some suboptimal wiring that we can improve the wiring and they can have improved performance. Yes, the question is, every brain has got some ragged edges that could get cleaned up, but there's what is symptomatic, what is really interfering demonstrably in quality of life and flourishing and preventing that person from really realizing their full potential. So where does that come from? I mean, there's so many things. I mean, let's go all the way to in utero and what is mom doing and what is mom's environment? Is mom in a stressed environment, and that little brain that's forming is getting all those stress hormones, right? So that could be it. I mean, there's just any number. And then of course there's developmental trauma, so an environment that just isn't optimized for flourishing. There's environmental toxins, so of course we know these days there's so much of that around, so that can interfere with brain development. We think about like when they brought in leaded gasoline, what a bad idea that was. The globe lost, I forget how many IQ points. It's a statistic, but globally human IQ dropped by putting lead in the environment. Yeah, so brain injuries, so many different causes. Yeah. So our process, we do our assessment. So that's the QEEG, the ERP, it's called an RFD. That's a lot of acronyms, but it's basically all of the data collection we do on the central nervous system and the autonomic nervous system. So then we put together a big report. We meet with the person, we do a report of findings where we go through, not all of, because these reports are hundreds of pages long. We hit the highlights and we look at the objective data, how that lines up with their reported symptoms. And we just kind of help create that map. We kind of call it a roadmap to treatment. So we look at that roadmap, and then we talk about what is a path forward in terms of treatment for that person. And is that going to be at-home neuromodulation? Is that going to be in clinic? Might it be following up with a functional medicine doctor to get a little further down there to balance some of the nutritional deficits that might be happening? Is there neural inflammation? Is there mold? Is there Lyme? We call those confounds that we would want to have remedied before we moved into treating the brain, so that we can treat the dysregulation that is there, but we're not trying to treat a brain that is being pushed in a direction by some other force that we're not taking a look at. And then typical, as it says up there, typical 40 sessions twice a week. That's kind of our standard protocol. Can we go away from that? Yes, but that's a very, an individual. This is kind of on average, people do 40 sessions twice a week. Some of our contact information. So, we're going to move into kind of demonstration. So Adam, are you all wired up? Yep. Okay. And we didn't say this at the beginning, should have slipped my mind, about questions. I appreciate that some of you have just been asking your questions. Great. We will have some time at the end for kind of a fuller Q&A, but again, anywhere along the line, feel free. So then Adam, what we have here is our lovely volunteer. She has the cap on. So 19 sensors, and those are picking up electrical activity. So when neurons fire, they create literal electricity. We can read that electrical activity at the scalp. And then the way that GPS works, right? So GPS, there's 3 satellites up in space that are triangulating your location. And the modern thing, like amazing thing, like if I put my GPS onto my phone and I walked across this room, you would see the dot moving, right? Like it can measure this distance of me moving 20 feet from a mile in space. So you can think about here, we have 19 satellites. I don't know what triangulating is when it's 19. I'm sure there's a Greek letter for it. But so what's happening is the data from each one of those sensors is being subtracted from the other sensors to narrow down what is the electrical activity happening under that sensor, right? So that's what we're seeing here is an EEG trace of each one of those. And then over here, this is a real-time comparison of the activity that we're watching here to the normative database. So again, an age and gender matched normative database where the Deep blue is telling us 3 standard deviations or more dysregulated. And deep red is telling us 3 standard deviations or more excess. So deficient or excess activity in the areas as we go. So then you can go ahead, if you want to move into air. So we're going to go into a training. So what we're seeing here is, so for the person training, this is their perspective. Her job, the instruction that we would give is get the plane to fly through the hoop. Right? And there's nothing you can do to make that happen. Imagine you're watching a friend play a video game. Right? You watching a friend play the video game. You're the mind, the friend is the brain. Right? So when she's doing this, her kind of volitional self is the mind, but the brain is flying the plane. Doesn't matter if she tries to lean in her chair or move her tongue to one side or the other or tighten her shoulders. None of that will change the plane in a positive way. What the computer is doing is taking those brainwave patterns, comparing them to a normative database for a particular network. Adam, do we know what network we're training? Default mode network. So we're training default mode network. And it's saying, how is her brain moving information through the default mode network right now? And the more that information is moving in a neurotypical way, the plane flies straight. The more it's moving away from a neurotypical activity, the plane goes wobbly. So basically, we're back to our operant conditioning of the feedback being yes, 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 no, 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 yes, 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 relative to the moving of energy around that brain. How many metrics are we training? So 386 different brain metrics being trained right now. Now, if you think about yourself, most people can't keep 2 separate lines of thoughts straight in their mind at a time. If you're really, really, really good, you could keep 3. But your brain can keep tens of thousands of things on track every second. So for the brain to train 350 different metrics, no problem. So do you have any sense of what you're doing? Exactly. No idea. And if she did have an idea, she'd be wrong, right? Because this brain activity is subcortical. It's outside of awareness, right? We can't control what neurons are firing where, in what sequence, in what network, outside of our ability to control. So I'll take them. So she needs the feedback. Her brain needs the feedback. This is a visual feedback paradigm. So her brain needs to see how's the plane doing. So the brain gets the yes, 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 no, no, no. And that's how it checks its behavior. Right? So the brain is going to be going like, you want more of this? Plane goes straight. Ah, yes. Or you want more of this? Plane goes wobbly. No, okay. I don't know what you want. How about this? How about this? But the brain can do, something like 14 billion calculations a second. So it can try all kinds of versions of you want this, this in milliseconds. And then it's getting feedback when it does something right. And then it goes, oh, more of that. So it does more of that. Oh, like this? Yes. Okay. Like this? Nope. More like this. Okay. Like that. It's just happening at lightning speed. So if we're doing audio training, because then it's the ears here in this. Sure. So Adam's going to show us right now. So right here. So this is our 350 different metrics that we're training. This is at what difficulty levels. so 5 standard deviations away from the normative database. That's quite a bit of dysregulation, 5 standard deviations. The only feedback is coming from these metrics that are crossing training line. Okay? So we're not at this level of training, we're maybe training 20 seconds. So how Adam is going to make it harder or easier is by changing this line. So here where it was flat like this, here where it touched the top, that was 100% on target. 100% lined up with the normative database. So go ahead and move this line down to maybe 3.5. So now it's right down here in the mix. So change our scale. So yeah. So you can see our training line is right down here in the mix. This is now going to be a lot harder because the brain has to try and figure out maybe 150 metrics instead of the 20 it was just doing. So we'll go ahead and run this and we'll look and see how you do. You'll also be able to see how wobbly the plane is. Oh, yeah, and Adam's doing exactly that. You can leave it up. This is harder. Yeah, so now we're getting her brain to train more metrics. So it has to be more of like this. Figure out fully multi-dimensional feedback to this unit. Figure out what is the system. When you said yes, what did you need? 150. So you were saying keep doing it. So the brain is just getting positive or negative. It's essentially just a binary, a yes or a no. Straight is yes, wobbly is no. Okay, old school neurofeedback, 2 lights, a green one and a red one. Green means good, red means bad, right? Or 2 sounds, a pre-sound and a buzzer, right? Brain just needs a yes and a no. It doesn't even need to know. It can do fine with just a yes. Just say like, yes, that, and no feedback for anything else, and you just get a yes. You get slightly faster results if you give the yes and the no. It's like creating brackets. But yeah, we gamify it to keep the mind interested, but the brain does not need the game. The brain could do this with a light bulb. Doesn't care. Just means, am I doing well or not? That's it. But the more we gamify it, the more the person becomes involved and they become more motivated. That motivation helps us. So, apologize. I was speaking past our Zoom folks. So my apologies, Zoom people. Yeah, so there's some specific things we can do. How are we doing on time? Okay, so we're almost there. So Adam, do you want to just quick change over to an outlier training? So this is a specific type of training where we're going to go after maybe 1 or 2 metrics. And this can be very helpful if there's a metric that's very highly correlated to a symptom, and we want to dial in on one specific brain region in one pattern of communication in one brain wave. And an example of this would be I had a gentleman I was training who was doing a lot of microdosing, experimenting with psychedelics, and he changed his visual system, which is fine when you're tripping, but when you're sober, going through the world and everything is technicolor, right? He was just walking around like, oh my God, I can't function in the world because everything is like super bright. So we found in his visual system where the specific area was, the specific little box, a little bundle of neurons that was misfiring. And through a training like this, we were able to go and pinpoint and train those neurons specifically. And within a session, we got rid of his visual artifact. So now what Adam is doing, you can see here, is it's only when this metric crosses the training line that there's any feedback. So the amount of feedback is much less, but these areas, so what are we at there, Adam? 15? So this particular metric is 15 standard deviations dysregulated. Like this area is very recalcitrant and does not want to give up what its dysregulation is. So we've made it, in a sense, easier because we're training one thing, but we've made it harder by we're training the very thing the brain really likes to do and doesn't want to stop doing. But it can be where we can get our biggest changes the fastest, is by going after the biggest source of dysregulation. But we also have to keep in mind that that's also the person's compensation method. It's like how the brain has learned to cope in the world. And if we take away their coping mechanism too soon, that can actually lead to more dysregulation. So as a clinician, you need to know when is the time to train gently and broadly, and when is it time to go and try and stamp on one variable. Oh, yes, HRV, thank you. Completely forgot we were going to do that. So, yep, Adam, go ahead and switch over. So this would be a great time if anybody has any questions. Sure, yep, I think I follow your question. So in neurofeedback, more so than in neurostimulation, so this is what we're doing here in neurofeedback, we think of the changes as permanent. So if we've got some neurons and some synapses that have developed a pattern of firing that is unhelpful, so we call it dysregulation, and we can retrain those neural circuits and those synapses into a more functional pattern, those will become permanent. So it's a little bit like learning to say, play an instrument, play guitar. If you really learn how to play the guitar and then you don't touch the guitar and you pick it up in a year, you can still play the guitar, right? But if you learned how to, you never really learned, but somebody showed you once how to play a song, if you never practiced, you didn't learn it, pick up the guitar a year later, you have no idea, right? Because you didn't build the neural circuits, you didn't create the learning. So that's why 40 sessions is in the beginning, we're creating change, we're pruning, we're learning, but somewhere around 20, we're going from learning to permanence, right? It's been wired in, now we're locking it in, right? I use the example of like, when's the last time you took driving lessons? Right? Probably when you were 15. Hopefully you're a better driver today than when you were 16. Didn't take any more lessons, you just do it, right? And you get better at it. Exactly. We change the brain uses those new optimal circuits every day to navigate the world. Every day it's locking them in and getting better and better and better at it. So we know a year after somebody stops neurofeedback, if we measure them at the end of 40 sessions, we do a neuropsych then, a year later, they're better. 2 years later, they're even better. 3 years later, they're even better. Because we've taught that brain how to optimize itself. It will then use that skill, presumably over the life course. We've only measured it 3 years out. But we assume at year 4 and year 5, that brain is still better than the day they stop neurofeedback. Yeah. Yep. Yes, absolutely. Great question. And I'll kind of go back to our mantra, which is we don't treat conditions. We regulate dysregulation. Underlying every one of these is a set of dysregulations. We regulate the dysregulation. So there really isn't anything. Right? You make a comprehensive list as long as you want, and the answer would be yes. We treat that because we regulate dysregulation. Mm-hmm. Yeah. Yeah, probably my biggest my biggest population of clients is dementia. Yep. And so we generally don't do neurofeedback with dementia. What we want to do is actually try and push back against the degenerative force. And so that's neuromodulation. So neuromodulation works incredibly well. If you can stop the degenerative process, then neurofeedback makes sense. But my thing has always been, if the house is burning down, would you put an addition on it? No, put out the fire, then build your addition. And so we think of neurodegenerative disease, whether it's dementia or Parkinson's or ALS or Huntington's or dystonia, as the house is on fire, right? What we want to do is put out the fire. Neuromodulation. So the device is at the back. So our main intervention for dementia is the helmet, the near-infrared helmet, and the audiovisual entrainment. We have just amazing stories of people who were non-functioning, who are now living normal lives. Driving, golfing, going to see the grandkids play hockey. Yeah, it's absolutely amazing. So Adam has pulled up our HRV. And so just a quick spin through here. I know we're running out of time. So this is the actual heart rate variability. So heart rate variability is the measure of beat to beat difference, right? So your heart should not beat like a metronome. So we always think about like, what's your heart rate? It's 60, 70, whatever it is. Like, oh, you've got a low heart rate, that's good. It is, but what really matters about your long-term health is your heart rate variability. And other things. Heart rate variability is a window into the function of your autonomic nervous system. It's saying, how well is your autonomic nervous system regulating the function of your internal organs? So imagine this. Well, we've got a friend from Arizona here. Sitting back, Lisa. Hi, Lisa. So let's say it's an average day in Scottsdale in the summer and it's 115 degrees, right? And you've got air conditioning, right? And you really like your air conditioning. Yep. That's a question. I'm assuming you do. Definitely, yes. So you don't want a thermostat that is going to say, let your house warm up to 115 and then try and say, cool it down to 50 and then let it warm up to 115 and cool it down to 50, right? That would be a bad thermostat, right? So what you want is a thermostat that is very narrowly controlling the temperature. Usually it's 2 degrees, right? You get 2 degrees, it starts cooling it. It gets it down 2 degrees below your set point, it stops cooling it. It holds it in a very narrow, that's what we found is that's the most efficient way to heat or cool a building is a very well-attuned thermostat. So your autonomic nervous system is the same way. You want it to be highly attuned so that it's running your heart exactly as much as your heart is needed for that moment. You don't want your heart running as I'm standing here, like it would be when I'm sleeping. That would not be appropriate for me speaking, right? On the other hand, if you're sitting in a chair, if you're you and you're kicked back, you don't want your heart running like you're doing a marathon, right? That's no good. So it's the same thing, but you want that for your heart, your kidney, your liver, your spleen, your large intestine, your small intestine, your stomach, your endocrine system, your hormones. You want all of those systems being run at a very precise level for what you need in the moment. And heart rate variability or biofeedback lets us look at your thermostat and see how well is it working. So heart rate variability is one of the things we look at is how well is the autonomic nervous system running the heart. And we're looking at that all the way down to the interbeat interval. So very small little metric. And it's one of the best predictors of all-cause mortality. If you know somebody's heart rate variability, you can predict very accurately not only their longevity, when will they die? You can't tell what they're going to die from, but you can tell the person who's going to have more encounters with the healthcare system. They're going to have more significant encounters with the healthcare system, that they will not do as well in their encounters with the healthcare system. And all of that leads to an earlier mortality. So our number one predictor of all-cause mortality is heart rate variability. It's a very important system in running our health. And the more we train it, the more health we get. If we look at aging, the entire science of aging, right here. All the longevity stuff this is what they're trying to change. So we're looking at heart rate variability, coherence, temperature, skin conductivity, peripheral circulation. This spectral analysis, very technical but important about how your heart is doing the job that it's doing. So like, what is the quality of the beat? And that tells us a lot about how much stress the heart, the cardiorespiratory system is under and how efficient it is. Right? So a lot of information here. So we're running this when we do a QEEG, we're tracking this. And then if necessary, we might do biofeedback with somebody versus neurofeedback. But a great case of somebody with lifelong chronic depression, had tried all the medications, all of the therapies, everything, just nothing was giving her the quality of life she wanted to. She came in for neurofeedback. We did a QEEG, did the process. We were doing neurostim, we were doing neurofeedback. We weren't seeing the change we wanted to. We took a look at her biometrics, and that was where her big dysregulation was. Within a few sessions of doing biofeedback, her symptoms radically changed, and she discontinued care. She knew her path out at that point. It's a very powerful system to address. And I'm pretty sure we're over time. So any questions about biofeedback or what we're seeing on the screen? So we can train this the same way, or not exactly the same, but similar to what you looked at with the neurofeedback. We can gamify it and have somebody change their temperature or their heart rate variability or any one of the metrics that we pick, peripheral circulation, and we can train them on that, and they can learn to change, say, peripheral circulation. Raynaud's, you ever seen Raynaud's? People, their arms tends to be, but it could be legs, are cold. They just look red. So with biofeedback, you can teach that nervous system how not to do that. You can train Raynaud's out of the nervous system. Yeah. So, and I would say one of the things for me, being a long time meditation teacher, a long time meditator. So I meditated for, I still do, but probably something in the neighborhood of 40 years. So, super mellow, laid back, long retreats, all of that. So my heart rate variability should be high because I am a trained relaxer. My heart rate variability is terrible. 40 years of breathing and meditating did not move my HRV an iota. A couple days of biofeedback moved it further than 40 years of meditation. Am I a meditation fan? Yes. Am I a breathwork fan? Yes, you should do those. Should you do those to correct your autonomic dysregulation? They're great for all kinds of things, but if you're not healthy, that's not your path out. We can call it here. We're going to be around. If you have questions, you're welcome to approach Heidi, Fran, myself, Adam. We've got devices in the back. If you want to try something, we can set you up for, we've got magnetic stim, we've got the near infrared light, we've got audiovisual entrainment. So if you want to try some of the things, you're more than welcome to.